In this video, we will discuss the most relevant topics regarding the treatment of malaria in India. Now, the treatment of malaria in India may be discussed under two headings, namely the treatment of uncomplicated malaria and the treatment of complicated malaria. The treatment of uncomplicated malaria may be again classified broadly into two headings: the treatment of uncomplicated non-falciparum malaria and the treatment of uncomplicated falciparum malaria. The treatment of uncomplicated non-falciparum malaria may be discussed in the form of this table. Now, uncomplicated non-falciparum malaria points mostly towards the management of malaria caused by Plasmodium vivax and Plasmodium ovale. So here what we do is we give the patient a treatment along a period of 3 days, day 1, day 2 and day 3. The drug that we give is tabchloroquine, 600, 600 and 300 milligrams respectively. Together with this, we give tabprimaquine, 15 milligrams daily for 14 days. That completes the treatment of uncomplicated non-falciparum malaria. Now, the treatment of uncomplicated falciparum malaria in India depends on which part of the country the patient comes from. If the patient does not come from a northeastern state, then the treatment would again be spread over a period of 3 days. On all 3 days, the patient must receive tab-artesunate, 200 milligrams. In addition to this, on day 1, the patient should receive a fixed dose combination of sulfadoxine and pyrimethamine at a dose of 1500 and 75 milligrams respectively. On day 2, in addition to artesunate 200 milligrams, the patient should receive primaquine at a dose of 45 milligrams, single dose. On the third day, the patient receives nothing but artesunate 200 milligrams. Now, if the patient happens to come from a northeastern state, then the previous regimen will not work. Instead, we need to give the patient, again, drugs spread over a time period of 3 days, day 1, day 2 and day 3. On all 3 days, we give 2 drugs, namely artemether and lumefantrine, and the dose at which we give these drugs will be 80 milligrams and 480 milligrams twice daily. In addition to this, tabprimaquine 45 milligrams is given as a single dose on day 2. Now, moving on to the treatment of complicated malaria, we have 2 regimens or 2 options that may be selected. The first is quinine-based therapy and the second is artemisinin combination therapy. Now, quinine-based therapy is an acceptable option if artemisinin combination therapy is not immediately available. So, if we are going to go and use quinine-based therapy, we need to give a loading dose of 20 milligrams per kilogram, and we should never give quinine as a quick IV bolus. We need to give quinine slowly over 4 hours in an IV fluid, preferably dextrose in normal saline or DNS. This may be followed by a maintenance dose, 10 milligrams per kilogram, Q8H or every 8th hourly. And again, this needs to be given slowly. The infusion rate should not exceed 5 milligrams per kilogram per hour. Once the patient is able to tolerate oral medicines, then we need to give the patient a full dose of ACT, again depending on where the patient comes from in the country. So that's regarding quinine-based therapy. If artemisinin derivatives are immediately available, then it should be started. It is the preferred regimen and the outcomes are better with parenteral ACT. So if this is the way that we are going to go, then we need to give artesunate at a dose of 2.4 milligrams per kilogram at 0 hour, 12th hour and 24th hour, and then once daily thereafter. And once the patient is again capable of taking drugs orally, we give the patient a full course of oral ACT depending on where the patient comes from. Now, let's move on to some of the individual drugs that we use in malaria, beginning with chloroquine. Now, let us say that this is a human red blood cell, and which contains obviously hemoglobin, and this red blood cell has been infected with a malarial parasite represented in blue. The malarial parasite has got a food vacuole represented as the green box. Now, once a malarial parasite infects a human RBC, it feeds on human hemoglobin in the vacuole. It breaks the hemoglobin into a protein part and a heme part. The protein part is digested, and the heme part, it is toxic to the malarial parasite. So the malarial parasite converts the heme to a substance known as hemozoin, which is absolutely safe for the malarial parasite. Now, if we give this patient chloroquine, it acts by inhibiting the conversion of heme to hemozoin. So heme accumulates, and as mentioned earlier, heme is toxic to the malarial parasite and the malarial parasite dies. So that would be the mechanism of action of chloroquine as an antimalarial drug. Yeah, so we discussed earlier the role of chloroquine in the treatment of malaria in India. Now, we need to also be aware that chloroquine and its congener, hydroxychloroquine, is not only used in malaria. It can be used in patients who do not have malaria, but who have other diseases, inflammatory diseases, notably inflammatory diseases that are mediated by immunological conditions, like, for example, rheumatoid arthritis. So in such patients, chloroquine and hydroxychloroquine do not act by inhibiting the conversion of heme to hemozoin. Indeed, these patients do not suffer from malaria. But chloroquine and hydroxychloroquine can act by inhibition of toll-like receptors in B cells and dendritic cells, and thereby they act as immunomodulators. Right. So chloroquine, in addition to being used in malaria, it can be used for other immunologically mediated inflammatory conditions. It is also indicated as a second-line drug in the treatment of extra-intestinal amoebiasis. It is not a first-line drug, it is a second-line drug in that condition. Hydroxychloroquine is indicated in a large number of diseases, notably systemic lupus erythematosus and discoid lupus erythematosus, in addition to, most importantly, rheumatoid arthritis. Now, regarding the adverse effects of chloroquine and hydroxychloroquine, these drugs can produce pruritus, discoloration of the nail bed and mucous membrane with bleaching of the hair. They can cause peripheral neuropathy and psychotic symptoms. They can also cause hypotension, auditory impairment or ototoxicity, lichenoid skin eruptions, T-wave changes in the ECG, and bullseye maculopathy, which is a form of retinopathy. Now, moving on to quinine and quinidine. Like chloroquine and hydroxychloroquine, quinidine and quin also act by inhibiting the conversion of heme to hemozoin, and quinine and quinidine produce poorer clinical outcomes when compared to artemisinin combination therapy. So it can be considered as a second-line drug in the treatment of complicated malaria. Now, a point to be noted about quinine and quinidine is that these drugs can produce hemolysis in patients by multiple mechanisms. One mechanism is by hypersensitivity to quinine and quinidine. So this ends up in a situation known as black water fever. So black water fever is a hypersensitivity reaction to quinine in patients with malaria. Quinine can also cause hemolytic anemia in patients with G6PD deficiency. So these are the two ways in which quinine can cause hemolysis. Now, what are the adverse effects of quinine and quinidine? Firstly, these drugs can produce a triad of dose-dependent toxicities, namely synchronism, hypotension, and hypoglycemia. By synchronism, we are referring to visual disturbances, high tone deafness, dysphoria, postural hypotension, tinnitus, headache, and clinically significant nausea and vomiting. In addition to these dose-dependent triad of toxicities, quinine and quinidine can also produce an anticholinergic effect on the AV node, resulting in clinically significant arrhythmias, notably Torsades de Pons. Now, quinine and quinidine can also cause severe clinically significant diarrhea, and as discussed earlier, it can cause hypersensitivity reactions in some patients, resulting in black water fever, which is characterized by massive hemolysis, hemoglobinemia, and hemoglobinuria. In G6PD deficient patients, quinine and quinidine can cause hemolytic anemia, and by poorly understood mechanisms, quinine and quinidine is also associated with the development of hemolytic uremic syndrome as well as thrombotic thrombocytopenic purpura. An important point to remember about quinine is that it is contraindicated in patients with myasthenia gravis, and if given to patients with myasthenia gravis, it can result in serious dysphagia and respiratory distress. Okay, now the artemisinin derivatives. Now these drugs do not inhibit the conversion of heme to hemozoin. In fact, the conversion of heme to hemozoin by the malarial parasite is an essential step for artemisinin derivatives to work. So, central to understanding the mechanism of action of artemisinin derivatives is that they have a unique structural property called EP bridges or endoperoxide bridges. So, when the malarial parasite converts heme to hemozoin, if we give this patient an artemisinin derivative, during the conversion of heme to hemozoin, the endoperoxide bridges get broken and free radicals are released. Now, this process is called reductive scission, and the free radicals are highly toxic to the malarial parasite DNA and results in the death of the parasite. So, this is the explanation of the mechanism of action of artemisinin derivatives. Now, artemisinin-based combination therapy or ACT involves combining a rapidly acting and rapidly eliminated artemisinin derivative with a partner drug which is slowly acting and slowly eliminated. The partner drug needs to have a mechanism of action that is different from the artemisinin derivative. Now, why do we administer artemisinin derivatives in the form of ACT? There are many reasons, but the most important reason is to reduce the duration of treatment. If artemisinin derivatives are given alone, it requires more than 7 days of therapies to eliminate the parasites, and this is a cause of concern in patients with severe malaria, in whom every minute is precious. So if we combine artemisinin derivatives with suitable partner drugs in the form of ACT, we can reduce the duration of treatment to 3 days. So this is the most important reason why we combine artemisinin derivatives with suitable partner drugs. And this is a summary of ACT. Examples of artemisinin derivatives include artesunate, artemether, and many more. Now let us move on to the life cycle of the malarial parasite and its pharmacological significance. The life cycle begins with the bite of a female Anopheles mosquito which is infected with the malarial parasite. Usually female Anopheles mosquitoes are vegetarians, but when they become pregnant, they feed on blood. So if this pregnant female Anopheles mosquito is infected with the malarial parasite, then it can cause trouble to the human being that it bites. Because when it bites the human being and drinks that human's blood, it will inject a form of the malarial parasite known as the sporozoite into the human being's bloodstream. These sporozoites immediately target the hepatocytes of the human being, which is represented by the black box over here. And once they invade the hepatocytes, most of the sporozoites get converted into the primary liver stage. Sometimes the sporozoites can get converted into a dormant form, and this is particularly true if the parasite was Plasmodium vivax or Plasmodium ovale. This dormant form is called the hypnozoite and is responsible for relapse of malaria many months or even years after the initial infection. Now, the primary liver stage will undergo a process called exoerythrocytic schizogony, resulting in the formation of thousands of merozoites. The merozoites leave the hepatocyte, enter the bloodstream, and target human red blood cells, represented by the red box over here. Once the merozoites enter the red blood cell, they multiply by a process called erythrocytic schizogony, of which there are two products. The first product is many more merozoites, which will eat up this red blood cell and destroy it, a process called erythrophagy. The red blood cell bursts, and these merozoites go and infect other erythrocytes and undergo erythrocytic schizogony there, and the process continues. So the other product of erythrocytic schizogony are the gametocytes. Now, at this stage, if this particular human being gets bitten by another female Anopheles mosquito, then that mosquito takes up the gametocytes from this human being. The gametocytes will then undergo a series of changes in that mosquito, culminating in the formation of fresh sporozoites in this new mosquito. Now, when this new mosquito bites another human being, the result is transmission of malaria. Right, so this is a very rudimentary explanation of the life cycle of the malarial parasite. Now, the merozoites, which we discussed. It is important to understand that the merozoites are responsible for clinical symptoms of malaria. And therefore, if we have drugs which are effective against the merozoites, these drugs would be useful in the treatment of clinically symptomatic malaria or acute malaria. These drugs will also be useful in another context. Let us assume that there is a person who plans to travel from a non-endemic area to an endemic area for malaria. So, just before traveling, the patient can be administered drugs which are effective against merozoites. So if this person travels to an area which is endemic to malaria and gets infected with malaria, the moment the malarial parasite enters the bloodstream in the form of merozoites and tries to attack RBCs, they get destroyed by this drug. And therefore, such a drug would be useful in preventing symptoms in the patient if given to them before traveling to that endemic site. Next, the hypnozoite. Hypnozoites, as we discussed earlier, are responsible for relapse of malaria months or even years after the initial attack. So drugs which are useful against hypnozoites, they can be given to patients who have proven hypnozoites in them. This is called radical cure. So a typical example would be a patient who is found positive for Plasmodium vivax or Plasmodium ovale. Such a patient would be given primaquine not for the treatment of the acute clinical symptoms, but so as to prevent the sure risk of development of relapse months or years later. In another situation, let us assume that there is a patient or a traveler who plans to travel from a non-endemic area to an endemic area of malaria, where the prevalence of malaria is more than 90% in the form of vivax or ovale. Now, even if that patient never develops symptoms of acute malaria, at least initially, we can presume that this patient might be harboring hypnozoites, and therefore we can give this patient treatment on the presumption that the patient has hypnozoites and may have a relapse in future. Now that's called terminal prophylaxis. Finally, there is a form of the parasite called the sporozoite, and as we discussed in the life cycle, the sporozoite is the form of the parasite that is responsible for the very first initial infection of the human being. So if you have a drug that is effective against a sporozoite, then chemoprophylaxis of malaria would be 100% effective. As we shall see later, such a drug doesn't exist. None of the drugs that are available at the time of recording have any effect against malarial sporozoites. Right, so understanding these aspects of the life cycle are key to understanding the concepts of chemoprophylaxis in malaria. So, the drugs used in malaria can be classified into three groups. Group 1. So, drugs that are included under Group 1 have got only one target. They target the merozoites. These drugs include mefloquine, chloroquine, quinine, sulfadoxine, pyrimethamine, artemisinin derivatives, and tetracyclines. They target only the merozoites. So, these are drugs that will be useful for controlling symptoms in acute malaria. They will also be useful in people who plan to travel to an endemic area. If we give such travelers Group 1 drugs just before the travel, then these drugs will kill the parasites after they have matured in the liver and emerged into the bloodstream, therefore preventing clinical symptoms of malaria in that patient in spite of being infected with malaria. So this is what we call suppressive prophylaxis, and it can prevent clinically symptomatic malaria in travelers. Suppressive prophylaxis needs to be continued for up to 4 weeks after return from the endemic area to the non-endemic area. It is also quite clear that Group 1 drugs are not effective against hypnozoites and therefore will not prevent a relapse. Group 2 drugs include atovaquone and proguanil. These two drugs are commonly administered together as a fixed dose combination. Being Group 2 drugs, they have got two targets, the merozoites and the primary liver stage. Since they target the merozoites, they are effective in the treatment of acute malaria, acute symptoms of malaria. And they are also effective against the primary liver stage. So if there is a patient who plans to travel from a non-endemic area to an endemic area, just before travel, the patient may be administered a combination of atovaquone and proguanil. So if the traveler gets infected with malaria during his or her stay in the endemic area, the malarial parasite will enter the liver and get destroyed at the primary liver stage. So this is what we call causal prophylaxis, or killing of the parasites while they are still in the liver. Now, Group 2 drugs do not have effects against hypnozoites, but still they are preferred for causal prophylaxis because of lack of adverse effects. The third group would be Group 3 drugs, which consists of only one drug, namely primaquine. Group 3 drugs have got three targets. They are effective against the primary liver stage and therefore They are effective for causal prophylaxis, although not preferred when compared to atovaquone proguanil. This is because primaquine can cause hemolysis in patients with G6PD deficiency. Right, so they are effective against primary liver stage. Primaquine is also effective against hypnozoites. So, if there is a person who is planning to travel from a non-endemic area to an endemic area in which the prevalence of the malarial strains consists of more than 90% of Plasmodium vivax or ovale, then even if this patient does not develop symptoms of malaria immediately, we can presume that that patient may be harboring hypnozoites, which can cause relapse in this patient months or even years later. In such a person, we can give him something called terminal prophylaxis or presumptive anti-relapse therapy. So this is done only if the traveler plans to travel to a place which is more than 90% endemic for Plasmodium vivax or ovale. It's not routinely given because primaquine can cause, again, hemolysis in G6PD deficient patients. Primaquine also has effects against gametocytes, and therefore primaquine is very useful in national programs to prevent the transmission of malaria. It's important to note at this stage that primaquine has no effect on the merozoites and therefore is not useful when the patient has got an ongoing attack of malaria. It will not control symptoms. Another point to note is that no existing drug has got any effect on the sporozoites of the malarial parasite. Before we proceed, we need to know the difference between the atovaquone proguanil combination and primaquine. As mentioned earlier, atovaquone proguanil has effect against merozoites and therefore is useful during an ongoing attack of malaria because merozoites are responsible for the clinical symptoms. Primaquine, on the other hand, has no effect on the merozoites and therefore has no role in controlling ongoing symptoms in malaria. It is useful to prevent future attacks of malaria in the form of relapse, but has no role in the treatment of ongoing symptoms. Right, so now let us discuss about primaquine. We have spoken about the role of primaquine in the various regimens of the treatment of malaria in India. We noted that in the treatment of uncomplicated non-falciparum malaria, that is malaria caused by Plasmodium vivax and Plasmodium ovale, we did note that primaquine is given at a dose of 15 milligrams for 2 weeks. Now, what was the purpose of giving primaquine in this situation? We know that primaquine has no effect on the merozoites and therefore will not be of any use in controlling the acute symptoms. However, we know that uncomplicated non-falciparum is caused by Plasmodium vivax or ovale and therefore hypnozoites will be a problem for this patient. Since it is almost certain that this patient will suffer from relapse of malaria in the future, the patient needs to be given primaquine to prevent certain relapse in the future, and this is called a radical cure. So the role of primaquine in the management of uncomplicated non-falciparum malaria is to provide radical cure. On the other hand, we do see that primaquine is given in the treatment of uncomplicated falciparum malaria all over India except the northeastern states, uncomplicated falciparum malaria in the northeastern states, and complicated malaria, whether you are using quinine or parenteral artemisinin derivatives. In each of these cases, primaquine is given at a dose of 45 milligrams on day 2 alone. We need to understand that Primaquine is not given here for the control of symptoms because, as we mentioned, primaquine has no effect on the merozoites. However, primaquine has got powerful effect against the gametocytes and therefore will be highly useful in preventing transmission of the disease, which is of utmost relevance in a national control program. And since we are following the guidelines laid down by the Government of India as part of the national program against malaria, the addition of primaquine here is very useful in the prevention of transmission of the disease. Again, primaquine will not control the acute symptoms in these conditions. Right. Now, when we speak about the prophylaxis of malaria, we know that primaquine has no role in suppressive prophylaxis because it cannot target the merozoites. It can be used as a causal prophylactic agent because it has got effect against the primary liver forms, but it is not preferred for that purpose because we have a safer option in atavacone proguanil. On the other hand, it is extremely useful for terminal prophylaxis, but whenever that is used, we need to make an assessment about the benefit to risk ratio. So only if the benefits of the drug outweigh the risks, we recommend terminal prophylaxis. Again, just to drive home the difference between radical cure and terminal prophylaxis, if we have confirmed that the patient is definitely infected with Plasmodium vivax or ovale, then the risk of relapse in this patient is definitely very high, and we will administer this patient primaquine to prevent relapse, which is almost certain to occur in this patient. That's what we call radical cure. On the other hand, there may be a person who is traveling from a non-endemic area to an area which is more than 90% endemic with Plasmodium vivax or ovale, and even if that patient does not develop acute malaria immediately, we can presume that the patient may be carrying hypnozoites, Plasmodium vivax or ovale, and therefore the risk for relapse in this patient, although unknown, is clinically significant. So we can give this patient primaquine to prevent relapse, which may or may not occur in this patient. That's what we call terminal prophylaxis, otherwise called presumptive anti-relapse therapy or PART. In fact, the latest literature is increasingly using the term PART instead of terminal prophylaxis. So, what are the indications of primaquine? They should be quite clear at this stage. Contraindications of primaquine include pregnant ladies, infants, and people who have documented G6PD deficiency. The mechanism of primaquine is at this point unknown. Now, what are the guidelines for chemoprophylaxis of malaria in India? Now, if a person plans to travel from a non-endemic area to an area which is endemic with malaria, and if that person plans to stay in that area for a duration of less than 6 weeks, then the Government of India recommends the use of doxycycline. It is recommended that the patient start doxycycline 2 days before the travel, and throughout the duration of stay, the patient should take a tablet of doxycycline once daily and continue to take doxycycline once daily for 4 weeks once the patient returns. So, let us assume that the patient returns from the endemic area to the non-endemic area. Upon return to the non-endemic area, the patient should continue doxycycline once daily for another 4 weeks. If, on the other hand, a traveler plans to travel to an endemic area from a non-endemic area, and that person plans to stay in the endemic area for more than 6 weeks, then the Government of India recommends that that traveler take mefloquine. Now, it should be started 2 weeks before travel, and the patient needs to take one tablet every week throughout the duration of the stay. Once the patient returns from the endemic area to the non-endemic area, that patient needs to continue tab mefloquine every week or once every week for the next 4 weeks. Yeah, so to conclude, this is a classification of antimalarial drugs on the basis of their chemical structure. We begin with the quinolines, which may be classified in natural or synthetic. The natural quinolines include quinine and quinidine. The synthetic quinolines include the 4 aminoquinolines, the 8 aminoquinolines, and other quinolines. The 4 aminoquinolines include chloroquine, hydroxychloroquine, and amodiaquine. The 8 aminoquinolines include primaquine and tefenoquine, and other quinolines include halofantrine, mefloquine, lumefantrine, and others. Next, we move on to the 9 aminoacridines, which include quinacrine, which is also known as mepacrine. The folate antagonists include inhibitors of dihydropteroate synthase and inhibitors of dihydrofolate reductase. Dihydropteroate synthase inhibitors include sulfadoxine, while dihydrofolate reductase inhibitors include pyrimethamine and proguanil. Remember, sulfadoxine and pyrimethamine are given as a fixed dose combination at a dose of 1500 milligrams and 75 milligrams respectively. Proguanil, on the other hand, is given as a fixed dose combination with atovaquone. Atovaquone is a drug that interferes with the mitochondrial membrane function of the malarial parasite. Artemisinin derivatives include artesunate and artemether, and finally tetracyclines include doxycycline, and we know that tetracyclines inhibit protein synthesis by interfering with the function of the 30S subunit of the protozoal ribosome.